Good afternoon. I'm going to present some data related to botulinum toxin use and its effect on Nocturia. I am self-funded for this meeting, and enclosed are my conflicts related to consultancies. So again, this is, on behalf of my co-authors, a paper looking at a post-hoc analysis of the patients that were accrued into the Onabotulinum toxin trials for regulatory approval. So therefore, you will see data that you've seen before, however expressly focused on Nocturia. For the purposes of this discussion, rightfully or wrongfully, the definition of Nocturia greater than or equal to 2 was chosen for the importance of the impairment on quality of life and other issues that are associated with that level of Nocturia. Again, the data for this report come from 2 phase 3 trials that supported the regulatory approval of OnabotulinumtoxinA for OAB. This was a post-hoc analysis with all the weakness inherent in that. Nonetheless, it was a post-hoc analysis to assess the effect on Nocturia in this particular patient population, inclusive of patient-reported outcomes in those individuals, again, who had equal to or greater than 2 nocturic episodes on a 24-hour basis. So these were 2 phase 3 trials. As I said, as you can see, the patients were assessed on the basis of 3-day diaries completed at various points during the clinical trial, 1 week, rather baseline, 1 week, 4 weeks, 12 weeks. As you can see, the patients were asked to keep not only their daytime frequency as well as their nocturic frequency. And the criteria for inclusion in this trial were patients who at least reached the threshold of equal to or greater than 2 episodes per night, and they could have no more than 1 nocturic-free episode night during that 3-day baseline diary. Assessments of week 12, again, were to explicitly focus on the reduction in nocturic episodes, and as you can see, there are 3 sort of separate arbitrary criteria chosen: greater than 33% reduction, greater than or equal to 50% reduction, and greater than or equal to 1 episode reduction per night based upon those diary-reported outcomes. There are also patient-reported outcomes included, specifically the subdomains and Kings related to sleep energy domain and change thereof, and then of course patient-reported outcome known as the treatment benefit scale, which essentially is a one-item assessment of the patient's overall assessment or lack thereof of improvement in their urinary symptoms, and then also give you a brief presentation of adverse events. These are the baseline data. Again, this is very similar to you. I stress the nocturic episodes, which were essentially equally balanced between the placebo and the active group. This is the first of the results slides. As you can see, this is frequency of nocturic episodes. You can see the baseline episodes per arm. Again, this you see the reduction in nocturic episodes. Again, this is statistical significance. We'll get to the clinical significance in a second between the onabotulinum 100 arm versus the placebo arm at 12 weeks. In terms of the patients who achieved the various levels of improvement that were pre-specified, as you can see, for 33%, 50% or equal to or greater than 1 episode, you can see that the active arm outperformed the placebo arm statistically significantly, again, given the baseline reductions as noted. When we look at the patient's perception of response, again, this is the subdomain of King's. This is not the King's total. This is a subdomain of King's related to sleep energy. You can see a relative significant disparity between the active arm and the placebo control arm, which again reached significance, especially considering minimally important difference. And then, as you can see, also in the treatment benefit scale, again, a substantial weighting towards the active arm versus the placebo arm, which are indicative of patient perception of improvement of condition. When we look at the overall side effects, again, not surprisingly, as we've seen, there are signals for urinary tract infection in the active arm, associated dysuria, and obviously retention as compared to the placebo arm, and again, also increased residual, obviously, in the active arm as compared to the residual arm, or the placebo arm. So in conclusion, Based upon this post-hoc analysis, again, this is a post-hoc analysis, this was not a prospective analysis, looking at patients who had baseline nocturia of at least 2 or greater episodes per night, there were significant reductions statistically in episodes of nocturia per night. There were significantly higher proportion of patients who achieved the 3 separate criteria for reductions in nocturnal voids. And I think probably the real take-home is a significant improvements both in the sleep energy domains in King's as well as the treatment benefit scale, which were noted. And again, not surprisingly, UTI and dysuria were the most commonly associated adverse events in both treatment groups, obviously more so in the active arm as compared with the placebo arm. And again, that's consistent with the intent to treat group. Thank you very much.
Thank you. Any comments or questions? So could you try to describe the patients, the ideal patient for Botox on patient with nocturia, resisting to agata to all kind of medication?
Well, keep in mind, Jacques, these were the standard patients that were included in the OAB trials, and these were patients who also had nocturic component of their OAB. So these are obviously patients who aren't necessarily the nocturnal polyuric patients. These are the patients with the functional capacity issues. So, I mean, the ideal patient obviously is the patient who's failed the appropriate first and second line therapies, who is willing to consider this as a separate independent intervention. Would I do this only for nocturia? Well, this is not what the question answered. I mean, obviously, have I done this in my clinical trial, in my own clinical experience anecdotally? Yes. Does it work for some patients with isolated nocturia? Yes, but again, that's when you factor out the nocturnal polyuric. So, but that's not the message of this particular paper.
Other comments, questions? Well,
thank you.
Thank you.